Free audio post-production by alphonic.com.
Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. Well, it's always good to host these brief conversations with members of our global community, and so I want to, as usual, welcome my co-hosts, Dr. Arjun Ghosh, Dr. Dan Lenahan. Arjun's in London. Dan is outside St. Louis. Welcome, guys. Thanks for being here today.
Great to be here with you all and looking forward to this episode as always.
Yeah, thanks so much, Steve and Arjun. I always look forward to these. So today will be another episode, compelling storyline from Cardio-Oncology, right?
Absolutely. It's a delight today to welcome Dr. Mohamad Khattab. Dr. Khattab completed his Cardio-Oncology and Advanced Cardiac Imaging Fellowship at Yale University of Medicine, School of Medicine. He currently practices at St. Francis Heart and Vascular Institute in Tulsa, Oklahoma, here in the USA. And he is an assistant professor for Oklahoma State University Cardiovascular Disease Fellowship, and he also serves as the Cardio-Oncology Fellowship Director there. So, Mohamad, welcome. Great to have you today.
Thank you very much for the kind introduction. It's really great to be here with you all today and contribute to this great program, the podcast.
Yeah, one of the things we always like to do is to get started is to just ask you to share with us a little bit about your personal background, your training, and in particular, how did you develop your interest in cardio-oncology?
So, as Steve mentioned, my name is Mohamad Khattab. I was born and raised here in the United States, in Tulsa, Oklahoma, actually. And so this has been a homecoming, coming home to start my practice. As you mentioned, I recently completed my Advanced Cardiac Imaging and Cardio-Oncology Fellowship training at Yale University School of Medicine. And I developed an interest in cardio-oncology during general fellowship training. For one, through the evaluation and treatment of ICI myocarditis patients on the wards. I think that was something that was new and interesting. And then through seeking mentorship at the national level through societies such as the ICOS and SCMR. So I was fortunate to work with Dr. Lauren Baldessari at Yale University School of Medicine, interviewed for a fellowship position there. And so now I've been fortunate to have training in cardio-oncology and further develop that interest through clinical practice and hopefully future research endeavors.
Thank you. That's very helpful to know. We appreciate that kind of background and context. And a couple of years ago, ICOS produced a paper related to radiation-induced heart disease. And this is an area, Mo, where we know you've done some work as well. And so our panelists, Dan and Arjun, have some questions for you about radiation-induced heart disease.
Great. Thanks so much, Steve. And Mohamad, very nice to kind of hear your background and how you got into the field. I know Lauren well as well, so say hi to her from my side when you next speak to her. So I guess you did a webinar with the team on radiation-induced heart disease, and it was so popular we decided to bring you back for part 2 of the podcast. So, here we are. And the starting question would really be a bit of background onto radiation-induced heart disease. So, how common is this? And, which are the cancers which are most problematic in this area?
So thank you very much, Arjun, for starting us off with a good question. I think that the incidence and prevalence of radiation-induced heart disease are highly dependent on the population being studied. and how many years out from radiation therapy or completion of radiation therapy they are. There is certainly incrementally increased risk with increased cumulative doses of radiation to a field that includes the heart. But it certainly is fairly common. We see that up to 60% of patients who have received chest radiation are noted to have valvulopathy at 20 years following chest radiation. And CAD was observed in 59% of patients in a case control study of non-Hodgkin's lymphoma patients with prior chest radiation. To answer the second part of your question, the cancers that are most commonly associated with this tend to be lymphoma, lung cancer, breast cancer, and esophageal cancer. Essentially, these are the malignancies that most commonly require radiation to the chest and to a field that includes the heart.
Okay, so you kind of mentioned that it can affect the valves, and it can also affect the coronary arteries. Any other parts of the heart that can be affected, and what's the mechanism, behind the damage?
Yeah. So as you mentioned, certainly the coronary arteries and the heart valves are very commonly affected by radiation therapy, but also the myocardium, the pericardium, and the conduction system can be adversely affected by radiation. Usually, radiation-induced heart disease manifests at least 10 years and sometimes 20 years after completion of radiation. But coronary artery disease events have occurred within 10 years. And so, in terms of the mechanism of radiation induced heart disease, the mechanism can differ depending on the specific structure or disease state involved. But the general mechanism is a robust inflammatory response to radiation in the acute phase, with subsequent development of fibrosis and collagen deposition in the chronic phase of the disease process, usually observed clinically many years later.
Yeah,
Anything?
this is a critical point. What you sort of said just a minute ago is what part of the body is radiated, and what cancer was being treated. Those are sort of the essential elements. And then, when you cite the cancers that are most commonly associated with some sort of radiation-induced disease, they're the ones that are in the chest. So lung cancer, breast cancer, esophageal cancer, those all have treatments that would involve something going through the chest. So therein lies the reason why you may see those conditions that have consequences of radiation-induced heart disease. But the other part, and this partially stems from the paper that Steve referenced earlier about radiation-induced damage. When you talk about head and neck cancer or prostate cancer, radiation is a huge piece of those treatment paradigms. And we don't necessarily think about the manifestations in those parts of the body. And, there's really no data that's sort of detectable about the ramifications of radiation from, say, pelvic cancers. How does it affect peripheral vascular disease, for example? Or, there's not a lot of data. There certainly is clinical experience about head and neck radiation and, the complex carotid disease that might result. So what is your understanding of those conditions as additive to what you've just said about the chest?
Yeah, so that's a really excellent point. And I think the European Society of Cardiology guidelines, the recent Cardio-Oncology guidelines, do mention these in the guidelines, and to consider screening for peripheral artery disease in those patient populations, the head and neck cancer, as well as the pelvic malignancies that receive radiation. But as you mentioned, in terms of data to inform screening, to inform management strategies, there really is a paucity of data in this space. And so I think that in my practice, for patients with head and neck squamous cell cancer, certainly if I hear a bruit on exam, then I evaluate further for peripheral artery disease or with a carotid ultrasound. But in terms of the asymptomatic patient, I think that I pursue testing and evaluation for carotid artery disease and peripheral artery disease on a case-by-case basis after shared decision-making with the patient.
Yeah, no, I think that's very reasonable. I would just encourage people that anytime somebody has radiation, certainly to the neck, you're gonna consider screening for carotid disease, even if you don't hear a bruit, because the bruit in and of itself is not really a good screening tool, and the extent of radiation-induced carotid disease is pretty substantial. So anyway, an ultrasound's an easy test to do, and it's not gonna harm the patient in any way. And of course, you have to think about thyroid disorders since you're having radiation into that area. And then the other clinical problem that we deal with in that setting is also autonomic dysfunction. So I don't know if you've encountered much of that in your practice. People, especially people with head and neck radiation, do they have substantial autonomic dysfunction afterwards?
Yeah, certainly. I probably am not aware of the exact proportion of patients that develop autonomic dysfunction, or certainly the proportion of my patient population that I see here that has autonomic dysfunction, but it is fairly common. And I think it becomes very challenging to manage hypertension in this patient population because they often have both hypertension and hypotension, and they have, as we colloquially mention, labile blood pressures. And so I think certainly autonomic dysfunction is common, and where that becomes most evident is in the management of hypertension in these patients.
One other very important point, obviously, and Arjun may have other questions in this regard, but what are the risk factors aside from people that get radiation? So what parameter would make them more likely to have the consequences from radiation?
Yeah, that's a really excellent question. And so I think, first of all, we have to remember that the same risk factors that predispose patients to heart disease in the general non-cancer population are still risk factors for radiation-induced heart disease. And this includes typical cardiovascular risk factors such as hypertension, hyperlipidemia, diabetes, tobacco use, obesity, family history of premature coronary artery disease, as well as pre-existing heart disease. The risk factors that are more unique to the cancer population include, as you mentioned, the cumulative dose of chest radiation. There are certain thresholds that have been studied, and I think the ESC Cardio-Oncology guidelines outline this well, that patients that have received less than 5 gray of cumulative radiation to the chest are considered low risk, and patients that have received greater than 25 gray of cumulative dose of chest radiation are considered very high risk. And then certainly concomitant use of anthracycline plays a role.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Right. That's very kind of interesting in terms of the risk factors. And I think just coming back to the point that Dan made in terms of the pelvic radiation, we produced a document in the UK from the Pelvic Radiation Disease Association, which actually deals just with pelvic radiation because it's quite a big issue with a lot of the gynecological cancers as well. And peripheral vascular disease is something that isn't really well identified, and the association is often overlooked, and maybe there is too much or an overemphasis on valves and the heart, and not kind of taking into consideration these other issues that probably as cardio-oncologists we should also be aware of. And Mohamad, in terms of the risk factors that you mentioned, I mean, how can we decrease the incidence? I mean, is it general risk factor control, or are there any other ways that we can try and prevent some of the damage?
Yeah, so as cardio-oncology specialists, we are well positioned to advocate for and support these patients throughout their cancer journey, and that includes a spectrum of pre-cancer treatment, during cancer treatment, and in the survivorship era after they've survived their cancer. As you mentioned, aggressive cardiovascular risk factor control is certainly recommended, but I think even more importantly, we can work in a multidisciplinary fashion with our oncology colleagues to discuss treatment options that either omit or at least limit radiation dose, particularly in high-risk patients.
And
Yeah, I think the other you sort of introduced this concept. So years ago, I can remember a number of patients, even 15 or 20 years ago, when I would see them and they said, "Yeah, I had radiation for sarcoma or lymphoma or whatever to my mediastinum back, 20 years earlier." And then now, if you were to see somebody that had chest radiation recently in the last couple of years, it's a completely different animal. Whatever chest radiation they may be getting now is much more directed or carefully prescribed than 20 or 30 years ago. So how do we help to minimize the impact of ongoing radiation now?
So that is an excellent question. I think that that in terms of minimizing the effects of ongoing radiation now in the era of more advanced radiation techniques such as immune modulated radiation therapy, photon therapy, SBRT, and as you mentioned, more sophisticated radiation therapy delivery algorithms that spare the heart, is going to be aggressive risk factor control. And so really having their hypertension, hyperlipidemia, diabetes very well controlled. And then also working with the oncologist to minimize anthracycline dose as the intersection of anthracycline-induced toxicity and radiation-induced toxicity seem to increase the risk at lower thresholds of each of those therapies than if you were to get one of those therapies without the other, if that makes sense.
Yeah, and I think deep inspiratory breath hold, and then other techniques that the prone imaging, et cetera, that the radiation oncologists have really upped their game in terms of how to do that. And even in current day, if they have some lung cancer and the tumor is sort of behind the heart, they I can position the patient in such a way that my SBRT is going to have minimal impact on the heart. That's kind of a concept that might not have been possible 10 or 15 years ago. And so it's quite impressive what they're able to do. And that's certainly going to help in the long run, no doubt. I guess my other question is, when we're evaluating this patients, and as you mentioned, controlling their cardiovascular risk factors is a basic requirement essentially for cardio-oncology. I would also add, looking at all the scans for the information that's available is an essential and required piece. And so I know you're familiar with the idea of looking at the vasculature for evidence of calcification and other manifestations of atherosclerosis.
Yes, that's a really excellent point, and I think that as we transition to talking about screening in this patient population, screening for coronary artery calcium is paramount. It's a really important part of screening the asymptomatic cancer patient who has received prior radiation therapy. Although I would caution that in prior observational studies, that not all patients have calcific stenosis, but rather fibrotic stenosis. And so, certainly with every patient that I see, I review their prior recent non-gated chest CT for the presence of coronary artery calcium. And if they have it, then as outlined in the Society of Cardiovascular CT Cardio-Oncology guidelines, this can inform decision-making on initiation of statin and or aspirin therapy. But then even in patients who do not have coronary artery calcium, patients who have received at least 15 gray of chest radiation, and who are 5 years out from completion of their radiation therapy, there is a recommendation per the ESC cardio-oncology guidelines that we should perform non-invasive screening for CAD, and that can include stress testing, coronary CT, etc.
And Mohammed, from the treatment side, because we've covered a lot about the cancers and the techniques to minimize and the risk and things, but unfortunately, some patients, of course, do end up developing the problems of radiation toxicity. So, are there any special considerations compared to non-cancer patients in this situation?
Yeah, that's an excellent question. So, in terms of how does treatment differ for these patients? These patients are very complex and challenging to manage effectively. Some of the challenges that are unique to the cancer population are the increased prevalence of coagulopathy that, when present, precludes continuous antiplatelet and or anticoagulant use, as well as limits percutaneous and surgical interventions. Um, in patients with advanced malignancies, a shorter life expectancy can deter physicians from proceeding with indicated surgical or percutaneous interventions. And lastly, the decision to pursue surgery versus percutaneous intervention is challenging in this population because, for one, there are no robust prospective studies comparing outcomes in both approaches. And moreover, surgery is higher risk in these patients due to a number of issues, including radiation skin changes and concern about wound healing after surgery, issues with lima patency in patients undergoing CABG, and lastly, calcified thoracic aortas after radiation that cause difficulty with cross-clamping of the aorta during cardiac surgery.
Yeah, I think porcelain aorta is a real kind of difficult one for the surgeons in this context, isn't it? So I think, interesting to hear that it is a challenge. And I guess in terms of the future, there's a lot of paucity of data. You already highlighted that, but for the community as a whole, would you suggest there are any areas that researchers should be focusing on to try and answer some of these questions?
Yeah. So I think that the biggest paradigm shift occurred in the last decade when we shifted our focus to prevention of radiation-induced heart disease rather than improved management strategies for radiation-induced heart disease. So as we've already mentioned, noting that, for example, the landmark publication in JAMA that came out in the last 10 years showing that when patients receive greater than 15 gray of radiation to a volume of the LAD that exceeds 10%, their risk for major adverse cardiovascular events increased substantially. This was really important, and this led to new and improved radiation delivery methods, which we recently discussed, including development of novel radiation therapy techniques such as photon therapy and intensity modulated radiation therapy, SBRT, deep inspiration breath holding, and prone positioning, as Dan mentioned earlier. But in terms of other areas of research, I think there's ongoing research looking at biomarkers of inflammation and fibrosis, such as myeloperoxidase and galectin-3, which may improve our ability to detect subclinical radiation-induced heart disease. Perhaps detecting the disease earlier can help us in monitoring and earlier treatment to improve outcomes in these patients. I think that there's going to be a lot more research in imaging and detection of radiation-induced heart disease in this patient population, whether that includes ultra-high sensitivity photon counting CT to better detect CAD in this population, or use of modalities such as stress MRI to evaluate for a multitude of different radiation-induced heart diseases, including cardiomyopathy, pericardial disease, is ischemia or coronary artery disease is going to be very important. This is an area that is ripe for research and has significantly changed compared to 10 years ago. And I suspect that it will likely significantly change again in 10 years from now.
Yeah, so this has been really great. I think, we're excited to think about how we can continue to improve things. I think the radiation oncologists have really responded to, the calls in the recent past to improve their treatment, and I think they're doing that in many, many ways. So I think cardio-oncology needs to do the same, to think about how we can prevent these problems from occurring, and how do we, in the case where it's already occurred, how do we manage them better? I think that's an ongoing question.
Yeah, this is great. Dr. Khattab, thank you so much for taking your time today. We really appreciate you sharing your insights. I know that our community will really benefit from the things that you shared today, and we look forward to having you back so that you can share with us some of the results of that ripe research that you mentioned there at the end. We look forward to that.
Thank you so much. It's been a pleasure, and I look forward to doing this again in the future.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.
Free audio post-production by alphonic.com.